Hello everybody, welcome to Fertility Fact or Fiction, the show where we review important fertility topics and reveal the truth about all things infertility. I'm Dr. Rahi Victory. I'm a Canadian and American board certified reproductive endocrinology and infertility specialist, and we do a weekly show where we answer all your questions. So welcome to Fertility Fact or Fiction. We traditionally have a setup where we will review an article, but our show has been running so long over time for the last several weeks that we thought this week we won't review an article and we'll actually just go straight into answering your questions. So we're going to let everybody jump on and we will start taking your questions right away. You can ask us pretty much anything about gynecology, about obstetrics, or about infertility, and I will do my best to answer. And a lot of times we're inspired by what you ask and we look it up and use it for our patients or our protocols. And so you sometimes are the sources of the next fact or fiction. So if you have an interesting topic, don't hesitate to ask. We would love to hear about what you're thinking of or what you want to know about. While everybody is logging on and hopefully jumping on with some questions, and you can post your questions on any of our platforms, we can see them all and we'll answer them. I want to talk briefly just about COVID and the vaccine. There are a whole lot of people that have been concerned about getting the vaccine and whether or not it will have an impact on pregnancy or miscarriage and so on. So a couple of things about that. Number one, there is now a published study in the New England Journal of Medicine that showed no increased risk of miscarriage compared to a background normal risk of miscarriage for people that were vaccinated while they were pregnant. So this vaccine really does seem to be safe and effective while you are pregnant. Number two, I do tell my patients, because many people have been asking about this, that if they are trying to get pregnant, they should get the vaccine and then wait 2 months. Why? Not because the vaccine itself will have any impact on your ability to get pregnant, because it doesn't, but because your immune system becomes very activated as a result of this vaccine. And when you have a highly activated immune system, there are some studies and lots of research out there that support the concept that an overly active immune system can sometimes interfere or reduce your chances of both getting and staying pregnant. So I personally encourage people to get vaccinated with at least their first dose. If you can get the second one within the 2 months, hallelujah. If you can't, the second one really doesn't generate that much immunoreactivity, so you're okay. But at least start with your first shot, wait 2 months, and then go ahead and do your embryo transfer or your IUI or whatever it is you're trying to do. In the meantime, going through an IVF process is not a problem. That's perfectly safe and harmless. And the last thing is there a risk to not getting vaccinated? What if you just wait? You know, you're too afraid, you're concerned we don't have enough data, you're concerned about the research, you want a little while longer. Well, the answer to that is there was a very well done study published about a month ago that I posted on Instagram where it demonstrated that the risks of pregnant patients getting COVID are so high that no one should even be thinking of doing that. Preeclampsia, miscarriage, preterm labor, preterm delivery, maternal ICU admission, God forbid maternal death, 22.3-fold increase in maternal death risk. So please get vaccinated. The vaccine is harmless to your pregnancy. It is harmless to you. It biologically cannot impact anything other than preventing COVID. There is no risk to this whatsoever. Thousands and now millions of people have been vaccinated in and out of pregnancy, and no one is reporting worldwide massive fertility problems. So, you know, and we're seeing patients every day and we're not seeing any issues. So don't hesitate to get the vaccine. Please get vaccinated. It's safe, it's effective. It is harmless to you. It is harmless if you're breastfeeding. It is harmless if you're already pregnant. The only time I recommend a delay is not a delay in getting the vaccine, but a delay in getting pregnant. If you've done your first shot, just wait 1 or 2 months. So hopefully we have some questions popping up.
Yeah.
And we'll start answering those. And if you guys have any more questions about the vaccine or data or anything like that, I'm happy to review it with you and we can go over it. And we got our computer set up here so I can actually pull stuff up while we're chatting. Fire away.
Okay.
Hopefully we'll get done by 9 tonight.
I had a 8-week miscarriage in November.
Sorry.
and a 5-week miscarriage a few days ago.
Oh, okay.
We are set to start IVF shortly. Any advice on what tests to do before IVF?
So I don't necessarily think you need to do anything before your IVF, although with 2 miscarriages, we would always do genetic testing of you. So karyotype for you, karyotype for your partner, because if one or both of you have any kind of genetic abnormality, it will drastically alter your outcomes with IVF in terms of success. Because if you have genetic abnormalities, you can be predisposed to producing far more genetically abnormal embryos than you normally would. And if that's part of the problem, you got to factor that into your math and your calculations as far as what your outcome is going to be. How high a chance do you have? Aside from that, most of the testing for patients that have recurrent pregnancy loss is not so much focused on the embryo creation part. It's more focused on the implantation part. So as long as you're not doing a fresh transfer, the testing should not necessarily interfere with your ability to do your IVF cycle, but you should be freezing your embryos and then looking at what you need to do to transfer. So for that, you need your vitamin levels checked. You need your genetics checked. You need to make sure that you're checking all your hormone levels, in particular thyroid antibody levels and your thyroid level. You need to make sure that you are checking for infections both inside and outside of the uterus. You need to look for your thrombophilia screen, and you need to see in some cases if there are any immunological problems that can be contributing. There are a variety of other things as well, but those are definitely the main categories. So those are the things we recommend that you take a look at and explore. And then you need to make sure that you're following a very holistic plan in terms of your weight, your diet, your exercise, your stress levels. All of these things are really important to manage, plus supplement intake and vitamin intake to maximize your chances of success with your cycle. So make sure you're approaching this from an appropriate sort of venue or pathway to make sure you're getting the best chance you possibly can. Arguably, for people that have had recurrent implantation failure, recurrent pregnancy loss, and you meet the definition for that with 2 miscarriages, some people would advocate that you should do PGTA testing of the embryos. So that's where we genetically test the embryos to see if they're normal. It does very much depend on your age, usually, but in a circumstance where there's recurrent losses, age isn't necessarily the only factor. And it may be worth considering. You should be talking to your RE or talk to us, and we'll let you know based on your whole history what the best path forward is. You need me to move that?
That's okay.
Here we go. Yep.
Okay. What if I'm scheduled to have a transfer in the next week and just now can get the vaccine? Should I cancel my transfer or just wait to see if the transfer works? And to clarify, I'm already on meds.
Yeah, I mean, that's a tough situation. If you don't mind canceling, that's definitely your safest overall option. There is no difference in your embryos staying frozen for another 2 months. So I would definitely say you're better off leaving your embryos frozen, getting vaccinated, stop your cycle, wait 2 months, do it again. To me, that makes much more sense. If you're going to go ahead, I would hold off on being vaccinated, because there's no question your immune system is going to be very active trying to produce antibody to, prepare itself for a coronavirus infection. And therefore, in that highly activated immune state, we don't know if it impacts fertility, but I personally, in an IVF situation, would not be willing to take the risk. Yeah, great question though.
AMH 3.37, just turned 40.
Nanograms or picomoles, does it say? Okay, yeah, just turned 40.
Yeah, just turned 40. AFC 6 to 8. Would you recommend a few rounds of IUI then IVF or straight IVF? What protocol would you use for IUI and IVF for someone like me? And what would be the success rates of IUI with injectables?
So if you were doing IUI, I need to know more about your history, but let's just take it kind of at face value. So if I was doing IUI, I would definitely aim for doing the shots. I think the injectables are a reasonable approach. It's at least going to give you your highest chance. we have a fact or fiction on how many IUIs are reasonable and what the outcomes are. It's about 15 to 20% overall at 40 for 3 tries, and above 3 it really doesn't work for insemination. Yes, I would probably recommend doing the shots. With IUI, the protocol is typically just the injectables, and then you use an antagonist to prevent you from releasing the eggs. And then you use ideally a double trigger, so that's Lupron and HCG. And that gives you your best chances overall. So that's definitely something you should consider. If you're thinking about IVF, IVF is definitely a great option and is going to up your chances. It also ups the cost. I don't automatically recommend it to everybody, especially because it's a big financial gap between IUI and IVF. But with 6 to 8 eggs, you would probably need somewhere between 2 to 3 cycles of IVF. And as long as you did that, you would likely get enough embryos to be successful with 1 live baby. Watch our embryo math video. I checked it today. We have 32,000 views now, which is awesome. So thank you to all of you that have watched. In that video, we really spell it out, and a 40-year-old is one of the examples that we use. So it goes through the math you need to know to figure out what your chances are. You're pretty much behaving like an average 40-year-old. So in that category, it's important to understand it will take 2 or 3 tries in many cases to get to just that 1 live baby. So as long as the financial component is not an issue for you, yes, of course, you should go to IVF. It's a much higher chance of success. But if the finances are a concern, or you want to try a little bit of a more gentle, natural approach, there's nothing wrong with trying a couple of IUI. It's perfectly legitimate. And we do that often with our patients. I don't push people into therapy. I always offer you your choice, and then I want you to decide what you think works best for you. I had a resident with me today, so as we were going through our cases, I was explaining to him, it's imperative that you always give patients the choice. So you explain, here's what's going on, here are the various options that you have, what would you like us to do for you? You never tell people you have to do this or you have to do that, unless it's super clear cut, like, the sperm quality is so bad, only one option is available, or the tubes are blocked, so you have to do IVF. Aside from those specific sorts of scenarios, people have options and they should be allowed to make their own decisions. Yeah.
Can you explain again why PGT testing isn't helpful for those under 38? Would it help with reduced chances of miscarriage?
So there's no data that it reduces miscarriage, and there is no data that it improves success rates when you're under 38. There is one very well done trial that we did review on the show called the STAR trial. And in that STAR trial, which was multinational, multi-center trial, they compared in a randomized controlled fashion patients that did PGT to patients that did not do PGT. There was no difference in the outcome. So it doesn't help you. And if it's not helping you, why are we lasering embryos and ripping off a part of their placenta? I mean, just biologically, that cannot be a good thing. They are not designed to undergo that process. So it's a very invasive process. And because of that, you really need to meet some kind of target threshold where you can say, okay, my chances of having a genetically abnormal embryo are high enough that it merits doing this. What's that threshold? To me, it's like when you're over 60, 65%. So that's at 38. So if you look at the graph in our embryo math video on YouTube, you'll see that at 38, you have about a 2/3 chance of having a genetically abnormal embryo. And so that just makes a lot of sense, because now if you do produce three embryos, 2 are going to be abnormal, maybe 1 will be normal. So that's a reasonable time to say, look, my odds are against me now. I should probably be sure that I'm picking the right embryo instead of having to pay for 3 separate embryo transfers to get to the one that's actually the good embryo. So to me, that makes the most sense, but obviously everybody's different.
Did the study about vaccine during pregnancy mention which trimesters they were given in? Do you feel it's safe at any stage of pregnancy, even very early?
Okay, so I'm actually going to spend a minute and explain to people what happens when you get the vaccine. So the I'm just going to stick to Pfizer and Moderna, okay? We really don't know about the cDNA ones, so let's stick with the mRNA ones. So the mRNA goes into your body, gets absorbed into some of your cells, and it sticks to this little spherical organelle inside your cell called a ribosome. The ribosome is like a printer for proteins. Okay, so the mRNA is the template. The ribosome reads the mRNA and says, oh, this is the protein I need to produce. And it sticks a bunch of amino acids together and assembles them, and now you've got your protein. The protein is a portion of the spike protein from coronavirus. It's a small portion. It is biologically inactive. It cannot do anything inside your body. Absolutely zero. It doesn't do anything. So once you've got the protein in you, the protein...
audio, we have to respool. The video froze for some reason.
Oh, okay. We're just going to respool the whole thing? The whole show?
No, like you just continue from where you left off. Just for some reason, the camera's not, like, I don't know if it's internet or...
Okay.
If I have all the chat, everything's okay.
What should I do?
But it'll be good for everybody. Okay, you're back.
Okay. Sorry about that. We lost the connection momentarily there. So what we then do is you've got your protein coming out of the cell, and it goes into your bloodstream, and your immune response is, hey, this protein doesn't belong here. Let's produce antibodies to it. So it makes antibodies to the protein. So the protein itself gets taken away immediately because your body recognizes it doesn't belong and gets rid of it, and now you're ready to prevent a coronavirus infection. So the issue with that whole thing is that can't impact anything. It's no different than getting a cold or getting a bacterial infection, strep throat or anything. You get something foreign in you, you mount a response, and this foreign thing has no biological activity whatsoever. So it's like inhaling a particle of dust. It does activate your immune system, and so you do need to be worried about the immune effects, but there's absolutely no impact on breastfeeding, babies, pregnancies, your fertility, all this stuff you hear about, like menstrual cycle alteration, and if someone's near someone that's being vaccinated, and that is the biggest load of malarkey in the history of nonsense. I mean, it is absolutely fraudulent that people are coming up with this. It has no biological sense whatsoever. This doesn't impact hormones. This doesn't impact your health. This doesn't impact anything. It just keeps us all safe. So for those vaccines, you really can't take them in any trimester. It's perfectly safe to do so. Would I do it in the first trimester? I'm reluctant to do it in the first trimester only because we know that 1 in 6 will have a miscarriage no matter what. And the people that have had the vaccine and have a miscarriage will inevitably blame the vaccine, even if it's not the vaccine's fault. And the last thing we need is for people to be telling other people that there's a problem with the vaccine. Are we good?
Yeah, you're good. I can't figure it out.
So, in any event, get the vaccine and don't worry about it. And if you're pregnant, get the vaccine. And if you're breastfeeding, get the vaccine.
Next question. What is the process for natural IUI and how effective is it? 40 AMH, 1.2 picomoles, low response to IVF meds, single female using frozen donor sperm.
So that's going to be pricey because you have an extremely low chance of success. At 40 with that low in AMH, your chances of success are going to be less than 5% for sure per try. And so you're spending, probably $1,000, $1,500 per try between the sperm and the meds and the IUI to achieve success. I would be very hesitant. I'd certainly help you. What's the process? If you're just doing a natural, it's easy. Go get monitored or don't, it doesn't matter. Monitor with an LH kit at home or go in for ultrasounds and blood tests. When your follicle's 20 millimeters, make sure you're triggering if it doesn't happen naturally, or if you want to let it happen naturally, that's fine. Wait for your LH surge. If you're doing a trigger shot, it's just one shot of HCG. 36 hours later, you get inseminated. If it's natural, usually we do it the day after you've had your surge. You get your insemination, and then we would recommend progesterone. And then you wait and you see. Vitamins, supplements, baby aspirin, that kind of thing can help, but it's a very, very low chance of success with that low an AMH and that age. So you need to be financially cautious there. It's working better now?
I don't know. I feel there's a lag or something.
A glitch in the system?
Yeah. What type of trigger shot do you recommend for IVF and why?
So you should be using a double trigger. So you should be using a Lupron or GnRH agonist trigger, and you should be using a small amount of HCG, because there are studies now that have definitively proven that the combination is better than just one. It has a lot to do with helping the final follicular maturation, and you want your follicles to be mature, so we always use both to maximize the chances. That's at least what we're doing, and we're even extending it to our IUI as long as the patients have coverage. That's your best chance of success. It minimizes OHSS, but maximizes follicular maturation and release. So that's the best you're going to get in that scenario.
In a natural transfer, when do you begin progesterone, and how much and what form do you recommend?
So it's usually LH plus 7, so 7 days after your LH surge. And so typically you would start it the day after so that you've completed your 5 days of progesterone when you're doing your actual transfer. And what was the second part?
How much and what form do you recommend?
So there is a study coming out. It's just being released in Fertility and Sterility, so it should be out soon, demonstrating that progesterone in oil plus vaginal progesterone is better than vaginal progesterone alone. We've been doing that since the beginning, so I've always done both, and that gives you your best results. So that's what you should try. So we use a combination of the oil and the vaginal. The dose depends on your body, so we titrate to each patient, like we check our patients' progesterone levels. But we use 50 milligrams of the oil, and then the vaginal depends on which one you're using. So it's 2 a day of crinone, 2 pills 3 times a day of prometrium, 1 pill 3 times a day of endometrine, unless you're using the custom compounded ones, and then it depends on the concentration and stuff. So
38 years old, AMH 2.3 nanograms per mil, 20 follicles at baseline.
wow.
All other labs normal, no male factor issues. Would 225 gonal, 225 menopur be a reasonable approach to stims?
How old is she?
38.
It's a little on the high side because your ovaries seem fairly robust, but it's not unreasonable. You can always taper down. There's 3 ways to do stim cycles. One is to start high and go down. One is to find hopefully the ideal dose and stay at it. And the other is to start low and go up. I'm not a huge fan of start low and go up because you have a time limited window to get the best egg quality. So that can be an issue. But in terms of start high and go down, we do that all the time. Ideally, you're just kind of at the right dose. 225 might be a bit high, but we've started lots of 38-year-olds at 225, and I wouldn't hesitate with you.
Hello to the best OB ever.
Thank you. That's very sweet of you to say.
How long would 1 or 2 or 3 rounds of IVF take from beginning to end? Say if I were to have a first consult with you in June.
So first consult requires testing. So there's usually about 6 weeks of testing. And then once you've done your testing, we circle back and we talk about all of the things that we found from your testing. We go through what protocol you want and how to do it. So it will very much depend on your age and the sperm quality and your health and many different factors. But assuming you're average, we can usually get you ready for IVF within a month or 2 at most. And then we tend to do a lot of frozen embryo transfers. So as long as your AMH is good, you're producing enough eggs, a month or 2 later, we would do your transfer. So how long it takes very much depends on how many embryos you produce, because we would certainly try and encourage you to use your existing embryos before having to pay for another cycle. So if you make, let's say, 3 embryos, that's going to take probably easily 4 to 6 months to go through. So you need a month or 2 to test, you need a month or 2 to do your IVF, and then depending on how many embryos you have, that long to go through them. And then if you needed to start again, then it's fairly quick doing another IVF cycle and more embryo transfers because you don't have that testing phase in the middle. So, on average, like a few months to go through the whole process. And that's to optimize your success rates.
What would you think would be the best route to take miscarriage 4 years ago? I'm 28, partner 38, and I have a child prior, different partner. Partner has slow sperm and mobility.
Depends on how slow. If they're very slow and the motility is very low, you may need IVF. You're certainly welcome to try IUI, but it depends on how poor the sperm quality is. So a question like that's kind of tough to answer unless I actually know what the specifics are regarding the results. But generally speaking, you're going to get a very good yield with IUI or IVF as long as the sperm is reasonable. If it's very poor quality, you need IVF. So it depends. I can't answer that without specific knowledge of your case, but IUI in general, like a natural cycle IUI, is going to give you anywhere from like an 8 to 10% chance. IUI with pills, about a 10 to 15% chance. This is per try. And IUI with injectables, around 20, 25% chance. So it's a reasonable chance, but again, it depends on your age. If you're over 40, those numbers come down a lot. If you're young and you're in your 20s, those numbers may be even a little bit higher. IVF, same kind of idea. The numbers go way up the younger you are and way down the older that you are.
Does a very low estrogen, 12.5 after FET, indicate something worrisome? Progesterone is at 45.
No, we don't worry at all about your estrogen levels. As long as your lining was okay, we don't really care what your estrogen levels are. That's not a problem. So your estrogen level can be whatever, you'll still be fine.
In a cycle following miscarriage, is it typical to ovulate, or is there a chance I may not?
In a cycle following a miscarriage, so you've miscarried, you've now had a full period come on, you should ovulate in the following cycle unless you were irregular before. So if you were regular to begin with, you'll go back to being regular.
I had a question about breastfeeding and the vaccine. I'm thinking about baby is over 1, but I want to make sure I'm able to transfer good antibodies to baby. How long should I breastfeed?
Well, you'll be passing passive antibodies to the baby for as long as you breastfeed. It'll probably kind of hit its peak around 2 months, but the levels of antibody actually stay stable for the next several months as well. So after your vaccination, you've got months of time to continue breastfeeding if you want to optimize passage to the baby. But keep in mind, those are passive antibodies, so they disintegrate in the baby and then they disappear. So it might protect your baby during that time that you're breastfeeding, but you can't go on protecting the baby forever. And babies don't really need that much protection because they do very well when they get coronavirus. So I wouldn't worry about that as much. It's the older adults and the people that are unhealthy that we need to worry about the most. Of course, we all have to be safe and all of us should take precautions, but babies are at extremely low risk. Yes, there are some babies that have unfortunately succumbed to coronavirus, but they're really very, very few. Very, very, very few. So delaying by a few months might be helpful. It might not. Nobody knows. It's certainly not going to be harmful. So there's no reason not to continue breastfeeding for a bit longer if you want to.
What should lining be on the day of FET?
Ideally around 8 to 10 millimeters. We can accept 6s and 7s sometimes. 8s are reasonable, 9s and 10s are reasonable. If it's too thick or too thin, don't do it. How's the tea?
Oh, fantastic.
It's good tea, eh? I know.
Good tea.
It's like a tropical fruity tea from Tetley.
I live in Toronto, and I'm with Create Clinic. If I decide to change to yours, how would that work since you already work with them? how would IUI and IVF and monitoring work because of distance?
Monitoring is not a problem because I do it all over the world with patients everywhere. We got patients all across Canada, all across Ontario. We can monitor you at different centers. We can monitor you at Create. We can move you to another clinic, whatever you want. So that's very simple to do. You're welcome to be monitored at Create and to continue your fertility care at Create, but under my direction. So that's not a problem. I certainly don't like stepping on anyone's toes, so I prefer to minimize the amount of doing that. But if you're dissatisfied or you want a second opinion, I'm happy to offer that to you, and then you can make your own mind up about whether or not we're the right fit for you. And then as far as where you get your treatment, we're happy to provide your treatment wherever you see fit. So I work with a variety of different clinics, and I don't believe in pigeonholing people into just one place. So Create's been great to us, and we're very happy with Create. But there are other places you can go to as well. So whatever you're most comfortable with. And monitoring's easy. I mean, I'm on my cell phone constantly because I run multiple clinics. So people are texting me, calling me. I review everything on my computer system, and that way I get a first-hand look to know what's going on.
My partner has low sperm morphology at 3%, but lots of sperm. Count 336 million. What perspective?
336 million? Or
Yeah, count 336 million.
wow. Okay, that's a really high count. Yeah.
What perspective should we have?
Well, it'll be harder because the number of normal sperm is so low. So your 336 million just became a total of 10 million normal sperm. 10.8 to be exact. So that's low. It's not a huge number. So you need to be cautious with the quality and what we're going to get. It may be more difficult for you to get pregnant, and that's what the data would support. You can, generally speaking, improve sperm morphology, vitamins, healthy diet, avoidance of everything bad, no smoking, no drinking, no drug use. And people always say, do you mean cut down? No, I don't mean cut down. I mean no smoking, no drinking, no drug use. So eliminate it completely. Take lots of vitamins, antioxidant vitamins, healthy diet, like I said. We believe in naturopathy. We're actually even going to be starting vitamin infusion soon through our naturopath colleagues and our own program to improve things. So, and I'm actually going to probably choose that as a topic next week for our Fact or Fiction. So yeah, I mean, there are different ways to kind of improve things for patients and see where it leads to. If that's still not working, then you either need insemination or you need IVF, where they can pick the sperm that has a normal morphology and inject it directly into the egg.
Do you believe taking low dose HGH for 30 to 60 days prior to IVF and throughout stims help with egg quality and euploid rate in advanced age patients?
It doesn't. So they've done a study. So years ago, there was this thing called the Cochrane database. I mean, not years ago, it's still there, but they had a study in it from years ago doing a meta-analysis on HGH, and they showed that it did improve live birth. But it was not really good data that went in there. Recently, they did another study looking, and it was just 2 years ago, 2019, where they did a randomized controlled trial of patients getting HGH and patients not getting HGH. There was no difference. So I don't use it because the data is pretty strong that it doesn't help. And I've used it before, like years ago, and I didn't see any difference. Nobody that I know of recommends doing it for 30 to 60 days. That is insanely expensive and going on for way too long. So I wouldn't recommend doing that for sure. Most people just use it kind of right before or during the stim phase. We are willing to use it if you feel that it'll help you, but the data doesn't support it.
Would you recommend NAC and inositol to non-PCOS patients? I'm 40 with low AMH.
Both of them are reasonably good anti-inflammatories. So if for any other reason you have inflammation, yes. So obesity, arthritis, autoimmune disorders, thyroid antibodies, anything that reduces inflammation will be beneficial. So they do have some anti-inflammatory properties, so it's a reasonable thing to use.
Hi, Dr. Vic.
Dr. Vic.
Dr. Vic, yeah.
I don't think I've been called Dr. Vic yet on this show. Cool.
Please, what's your advice? I just got my scan results. Uterus is bulky, measuring at 12.8 centimeters by 8.7 centimeters.
Okay.
Multiple uterine fibroids are noted. The largest is seen at the fundus and subserosal in location and measuring 9.5 by 8.2 by 9.2 centimeters.
Those need to come out, yeah.
Previously, 4.5 centimeter, the double layer endometrial is 10 millimeters, which is within normal limit. The ovaries are unremarkable. No adnexal mass is seen.
Sure.
There is a trace volume of free fluid in the poster cul-de-sac.
What to do?
The question ends. I'm just trying to see if it just got bumped somewhere.
So you should get your fibroids removed. I mean, I know where that's heading.
Yeah.
That's a big fibroid.
Oh, yeah. So sorry to interrupt. So this is the thing here, and can I still get pregnant with the fibroid?
Yeah, you can get pregnant with the fibroids. They could cause complications, bleeding, preterm labor, pain, that kind of thing. If you're doing IVF and you have lots of embryos, you could always try one and see where it leads. Generally speaking, if the fibroids are that large, I would recommend removing them. I wrote a chapter for a textbook on fibroids, and it's pretty clear from the data that it is supported to remove the fibroids if they are large or they're deflecting the inside of the uterus. So you should start with a saline infusion sonohystogram. But a 9 centimeter fibroid, that's inevitably going to cause you problems. So I would get that taken out. Yeah. If it degenerates during your pregnancy, you will be in a hell of a lot of pain, and it is an increased risk for preterm labor. Complicated delivery, that kind of thing too.
I had a miscarriage last year at 8 weeks. Is it possible for a chromosomally abnormal fetus to grow up to 8 weeks and actually have a proper growth and strong heartbeat at 7 weeks?
Yeah. Well, I mean, Down syndrome kids are chromosomally abnormal and they make it right through to the end. So are Turner's children. So yes, you can easily have chromosomally abnormal fetuses grow and develop and have heartbeats. Even trisomy 18 and 13 can grow and have a heartbeat. They can continue growing. They can make it to live birth. So it's very possible. Yeah, good question.
Do you do the transfer yourself for trauma patients? Can the partner be in the room? And how is the cycle monitoring done for trauma patients?
I do the transfers myself, yes. The cycle monitoring is done wherever you want to get it done. We have a variety of partners we work with, and it's easy to do, so that part's easy. You just go in. Like, keep in mind, no matter what fertility center you're working with, it's rare that the doctor is doing the monitoring. And I think there's actually some detriment to that because it's nice to have it very uniform. And I'd rather be helping patients who need me to talk to them rather than be sticking an ultrasound wand in, which a technician can do just as well as I can as long as they do it my way. So we monitor patients with blood work and ultrasound all over the place. That's not really critical. What's critical is making sure we do a good embryo transfer when the time comes. So the monitoring is easy. The processing of that part is easy. Transfer is fairly straightforward, and we can do it wherever you want it done. So you can have your embryos shipped to us, or you can keep them in Toronto and we see you there and take care of you there.
Is it safe to get vaccinated if you're trying to get pregnant? I'm on a few types of meds.
So as I mentioned at the start of the show, you may have missed it. It is safe, but it will activate your immune system. And so the chances of success are probably lower. I say probably because we have no evidence at all. So I suspect, and I want to be very clear about this, there's no evidence out there, but I suspect it may be very temporarily, exactly 2 months, harder to get pregnant during that time and or stay pregnant. That's if you get the vaccine and immediately conceive or try to conceive. So for those who are trying, if it's natural, I don't think it's that much of an issue. Get your vaccine, go ahead and try. If it works, it works. If it doesn't, God forbid you have a miscarriage. That's, part of the biology of going through life. If you get the vaccine and you want to wait 2 months. That's all it takes, and then you should be normalized after that.
Do you recommend Neupogen to help with failed implantation, injection, or wash?
There is some data that Neupogen does actually improve chances. I don't think we've done a fact or fiction on that. We got to do one on growth hormone. We got to do one on Neupogen. You know what? Maybe I'll take that as a topic. We got to make a list. So I'll present that in one of the upcoming ones. So there is data that suggests that Neupogen.
Okay,
Yeah, there is data. And it does suggest that it can be beneficial. I don't use it because the data is not that strong yet, but you know what? It might be time for another look. There are some studies that have actually looked at putting Neupogen into the culture media and suggesting that that makes a difference. And I know one fertility center in the GTA that charges an insane amount of extra money to use that for patients that have had previous failures. We carry some here for the cases that we think might need it. We don't charge extra, so it's much more expensive, but I'm not going to charge people extra for something they need. So yeah, I mean, it's available and it might make a difference. It's a good fact or fiction topic. Remind me to do Neupogen.
A good question for you.
Okay.
Is age the only criteria that would make you consider PGT? Would you recommend it for a 31-year-old with low AMH and endo?
Okay, so your endo is irrelevant to your PGT. Your low AMH is relevant because if you watch a fact or fiction we did about 5 or 6 weeks ago, we talked about the impact of low AMH on the chances that your embryos would be genetically abnormal, and there is a higher chance of having an abnormality. So when we talk about age, we're probably talking about the wrong thing. We should probably realistically be talking about your individual risk of having a threshold of abnormal embryos that is higher than ideal. I know I'm being kind of cagey or vague about those terms, but for me, to be specific, I feel that when your risk is 2/3 abnormal embryos, 1/3 normal, it's worth doing. Just even financially and common sense, right? It just basically means that you've got a higher chance of failure than you do of success. Well, that's the right time. Now, some of you might say, well, why not 51%? That's fine too. But for me, 2/3, 1/3 just makes sense. It's arbitrary, but to me, it's Rahi logic, or victory logic. So I like that number. So if your ovaries are behaving like a 38-year-old, then yeah, you should probably do it. If your ovaries are behaving like a 40-year-old, you should definitely do it. If your ovaries are behaving like a 32-year-old, then don't. So low AMH is a criteria. Age obviously is a criterion. And previous history of failures, and previous history of genetic abnormalities, and previous history of recurrent pregnancy loss. Those are all pretty good indications for PGT. I'm not opposed to PGT. We do PGT all the time here. I'm opposed to it for patients that don't need it because you're really savagely attacking the embryo when it's not indicated. So for example, we have lots of places, again, numerous places throughout the world that are telling patients if they're doing donor egg IVF, they need to get PGT done. The truth is, yes, you will get some genetically abnormal embryos with with donor egg IVF. It does happen, but the chances are very, very low. And based on that study we reviewed last week, it's totally unnecessary because it doesn't improve the chances. So if I'm going to be doing something, it's either got to make a positive difference or at least be worth the risk or at least worth the cost. If it's not doing anything, then it's certainly not worth the risk, and it is definitely not worth the cost. So that's not something I can stand behind.
What do you recommend for fully unexplained infertility? Regular cycles, ovulation confirmed, great sperm, no endo, hormones good, AMH good, fertility clear. What can we do? Tried 6 medicated cycles. Did 3 IUI as well.
Okay, so medicated cycles are useless when you are doing or dealing with unexplained infertility because just medication for unexplained does not work. We know that. So patients with unexplained infertility have a 3.1 to 4.3% monthly success rate, and taking the medication makes it 3.8%, so it doesn't help. medication with IUI, and that can be oral meds or injectable meds with IUI. IVF and surgery are the only 4 things that work for unexplained infertility. I don't think we've had a show where I haven't said that. Like literally from day one. It's on every single show. So listen, if you have unexplained infertility, you must explore one of 4 potential options. So number 1, it's pills and insemination. That gives you a 7.8% chance. Number 2, it's shots and insemination. That actually really bumps it up to about that 20% mark, maybe a little bit lower, but in that vicinity. Number 3, IVF, by far your highest chance. And number 4 is doing surgery, because some of those patients with unexplained actually have endometriosis and they need to deal with that, or you may have tubal damage or adhesions or something else going on, and the surgery is what will reveal that possibility. The other thing that is up and coming, although we don't have data yet, but it's probably worth a good study, is whether or not DNA fragmentation increases the risk of unexplained infertility. And a lot of times people are not getting the DNA fragmentation done, so we don't know if that's a component of it, but it very well may be. So maybe that's something for us to research, and that's something we might take a look at.
Is there a wait time trying to conceive post-vaccine if conceiving naturally?
No. I think if you're conceiving naturally, as long as you acknowledge that there is a miscarriage potential, no data, but there is a miscarriage potential if your immune system is very active and you do become pregnant, then I think you're fine to go ahead. Keeping in mind that the newest data, which is just released, I think a month ago, suggests that there is no increase in risk, so it is perfectly safe. So the New England Journal study said there was an 11% miscarriage rate, and if there's only an 11% miscarriage rate, that is actually lower than normal. So there's no increase for sure based on the data we have so far.
Is there a concern about reactions to COVID shots, fevers, chills, etc. in pregnancy?
Fever, if you have a bad reaction, fever can cause a miscarriage, guys. So if you have a very severe COVID reaction, you could run into trouble. Yeah.
Hi, Dr. V.
Hello.
Thanks for meeting my husband and I Saturday. Just wondering when I should be hearing from the clinic for next steps. Also, started P90X3 with T25, and my legs are like jelly.
That's awesome. And the clinic was instructed, so they should reach out to you. I know who you are. They should reach out to you. They should have reached out to you today, so I'll double check what happened and I'll let you know. But thank you, and I'm sorry you're like jelly, but they will be rock hard and super strong in literally like a week or 2. So hang in there. You'll get very, very strong from that combination. Extremely strong. And good for you. That's a tough combo. Really, really tough. I don't think I could do that. Yeah.
Taking 8 1 milligram estrogen pills a day, baby aspirin, and soon to start progesterone oil. Does this sound reasonable for an FET protocol?
It's really tough to answer that. So we try where we can to avoid estrogen, but in some patients you have to because their lining is too thin. So if you can avoid estrogen, you should. So we use letrozole, and then we try to avoid the estrogen pills. That's a fair bit of estrogen. It doesn't mean it's wrong. We just like to avoid it. It's not great to be on estrogen when you're trying to get pregnant. But it's reasonable, and your progesterone just has to start when your lining is the right thickness.
With someone diagnosed with male infertility, main issue being poor motility, would you recommend doing genetic testing if no underlying cause has been found?
Okay, I'm confused. So if you mean genetic testing of the male just because he's got low motility, no. Genetics doesn't usually play a role in low motility. It can play a role in no sperm, but I'm not aware of any genetic problem specifically that reduces your motility. I'm sure there is something, but none that we're aware of. Cystic fibrosis would potentially be the only one. So yeah, I wouldn't go looking for genetic reasons for motility concerns. If you're worried about miscarriage, or you've had multiple miscarriages or multiple failures, that's a different story, but not strictly based on the motility of the sperm, if that's what you're asking. Sorry. Yeah.
28 years old with 2 failed transfers. Should I thaw, test, and refreeze my remaining embryos?
No.
Or do a new stim cycle with testing?
I would figure out why you failed. So being 28 and failing 2 transfers is odd, but I need to know why. So I would hit the pause button, do not do another transfer, spend the time to figure out what's wrong. Immune system, test your genetics and your partner's genetics, test this sperm DNA fragmentation, do the fertility testing, look at your vitamin levels, check your thyroid, endometrial biopsy if you have to. It's painful and horrible. I apologize to those of you that go through that. If you need to, check your immune system and your immune function. There are loads of things to explore. Do not do another transfer until you have an answer. It is unusual, not unheard of, but it's unusual to be 28 and fail 2 transfers. You're young. Unless there's a problem with your AMH or your ovarian function, there shouldn't be a reason. Now, weight can be a factor. Your partner's weight can be a factor. Sperm DNA fragmentation can be a huge issue. If somebody's smoking, drinking, using marijuana, all of those are huge factors. So it depends on what's going on.
When you say it can take 2 to 3 tries for IVF success at an old age, do you mean 2 to 3 full IVF cycles?
Yeah.
Or 2 to 3 embryo transfers?
No. So, well, that depends on whether you've genetically tested your embryos. So over the age of 40, you are likely going to need 2 to 3 IVF cycles, full cycles, to get enough genetically normal embryos to achieve 1 live birth. So just to kind of put it into perspective, we know you need 3 genetically normal embryos to get a 95.2% chance of live birth. In order for you to get 3 genetically normal embryos, you need a lot of eggs at the age of 40, because we know about 75 to 80% of your embryos will be abnormal. You need roughly double the number of eggs to get that number of embryos. So just do the math. If 80% are abnormal, that means you need 5 embryos to find 1 normal one. Okay? 4 will be abnormal, that's your 80%. 1 will be normal, that's your 20%. So then in order to get 5 embryos, you're probably going to need somewhere around 8 to 10 eggs. Let's just play it conservative and say 10, because you need to fertilize them and then they need to turn into blastocysts. So 10 eggs will get me 1 genetically normal embryo. If I need 3, I need a total of 30 eggs. For most women over 40, that's not even possible. Certainly not in 1 cycle. And even in 3 cycles, some women can't get that many eggs. So you may get great results, you may get terrible results. I just had a patient that did an IVF cycle with us. She is over 40. She actually had a reasonable number of eggs, and we got her genetic test results, and the majority were abnormal, but she has 2 beautiful genetically normal embryos. So, you know, she got 2 normal embryos from 1 cycle, so she would just need 1 more to theoretically get that guarantee of a live birth. So there are some people that do better, and certainly your program has a lot to do with it too. So, you know, to beat the odds of the genetics, there are variations in the genetic normalcy of embryos based on the center you are working with. The protocol probably does make a difference. And there's some data that supports that. The embryologists make a difference. How long you leave the eggs out makes a difference. So there are a variety of factors that go into this that can really alter things for you. You know, I need to get you one of these Ember mugs because we got to keep your tea hot the whole time.
Got cold in the end. Iced tea.
I know, it's iced tea, yeah. We're gonna get Tarek his own Ember mug. I got one of these Ember mugs and it keeps things hot and it's awesome. So thank you very much to the lovely family that bought that for me as a gift. I love you guys. Yeah.
I love you too, don't worry.
Yeah.
Who'd benefit from DuoStim and why is IVF so expensive?
DuoStim, anybody with weak ovaries that has like enough eggs to produce a few more in that second cycle, will benefit, and also people that have had not a great result. Sorry, we had like a minor height problem there.
Collapse on us.
So it's still going down.
Okay.
I think you're way off screen there. Yeah, that's probably good. Yeah. So people that have reasonable ovarian function but not great, low AMHs, your antral follicle counts like 3 to 6 or 8 or something like that. That's all very reasonable for Duostim. Why is IVF so expensive? Okay, this building, I won't go into huge specifics, but I'll give you the general specifics. This building cost us millions of dollars. The IVF equipment cost us close to about $1 million. And then every 5 minutes, my amazing, and I love her to death, lab director says we need better equipment, or not better equipment because we've already got everything at the best, but she'll say, hey, I need a new microscope, or we need a time-lapse embryoscope, or we need something different. All of this stuff is psychotic. We just got a time-lapse embryoscope. It's $160,000 US plus running fees. So this stuff is insanely expensive. The needles we use are hundreds of dollars. The media, just a few drops that she uses to put your eggs in, it's insanely expensive. It's literally thousands of dollars for the media alone. So that's before we even get to electricity, nursing staff, telephone lines, internet service, social media guy, all of the other stuff that we need. So it's incredibly, incredibly expensive. Just the costs alone are staggering. So that's why it's expensive.
I'm 30. Have hypothyroidism. Tracking my BBT and temps are lower than normal, but there is an increase in temps that would suggest ovulation. Could low temps be a sign of low progesterone?
I'm going to apologize for saying this, but abandon using your basal body temperature. That's useless. It's a total waste of time. Use an LH kit. If your LH kit demonstrates that you're surging, you're surging. If your LH kit is negative, your temperature is meaningless. That is incredibly unreliable. So nobody uses basal body temperature for this unless they are doing it at home like yourself, or they actually scientifically, from our perspective, don't know what they're doing. So we don't use that at all. Cycle monitoring works, LH monitoring at home works, but basal body temperature is highly, highly unreliable. If you have a fever, an infection, inflammation, allergies, you slept under a hotter blanket, your temperature will be altered. So don't bother with that. Can it be a sign of low progesterone? I am not aware of any connection or indication that basal body temperature is correlated with any hormone state because it's so unreliable. But you can easily get your progesterone measured. So that's easy. Go and get your progesterone measured. It's just a blood test.
So I would like to inform you that it is 8:59.
Woo!
But I would also like to inform you that
There's 8,000 questions.
8,732 questions.
We had some glitches. You want to do an extra 10 minutes?
For sure.
All right, we'll do an extra 10 minutes, guys, because we had some technical glitches, including the fact that Tarek thought I was a dwarf and dropped the camera down. Yeah.
Nearly 39 years old. My only previous success was with a fresh transfer. I'd like to do another round of IVF soon. Would it make sense to do a fresh transfer and PGT test? Any remaining embryos?
Oh, that's interesting. So the writer is asking if she produces, let's say, 5 embryos, can we do one of them as a fresh transfer and then PGT the others? So part of the reason that we do frozens is that if your estrogen level is high or your progesterone level prematurely rises, which frequently happens when you have lots of eggs, then your chances of success are low. If your estrogen's too high and your progesterone's too high, you're literally on birth control. That is not going to work. It drastically reduces your chances of success. So we don't recommend that most of the time. Typically, we will go with doing a frozen embryo transfer for you, which will give you a much better chance of success. I like your idea, and it may be reasonable in a scenario where you're only producing like 2 or 3 embryos, your estrogen never got high, your progesterone stayed quite low. That would be cool. I've never really thought of doing it that way before. The problem is you really don't know what you're putting inside yourself, and if it works, hallelujah, but if it doesn't work, you don't know if the problem was your body, your lining, your hormones, the cycle, the embryo. You have no clue. So I would probably recommend you just do the PGT on all of them. Right now, in the right hands, with the right protocol, I'm always really careful about what I say, frozen embryo transfer should at a minimum be equivalent and likely be higher success than using a conventional fresh embryo transfer. So we get phenomenal success rates by just using our frozen embryo transfers. So I wouldn't worry about that at all.
Can seraptase reduce size of fibroids and
Adenomyosis?
Adenomyosis.
What is the thing?
Seraptase.
Let me see.
It's a new word for sure. Word of the day.
Where is it?
The blue.
Serapeptase. Never heard of it before. Let's find out.
Fact or fiction?
Yeah, let's find out. lib.uwo.ca. Here we go, folks. We're going to find out. Ask me another question while I'm searching.
Yeah. Does pre-seed help the sperm to move better, or does it just harm the pregnancy? In other words, is it better to
Harm
use
the
pre-seed
pregnancy.
or not if you don't really need it?
So pre-seed has no negative impact on sperm. If you don't need lubrication, you don't need lubrication. But if you need lubrication, you should use pre-seed. Serapeptase and fibroids. So this is a PubMed search, guys. Your search was processed with 0 results. So there is nothing about serapeptase and fibroids. So I cannot tell you because nobody has looked at that. Interesting.
Is it true that you're more fertile after a miscarriage?
No, that is not true. It's totally not true. You may be more fertile if you've had a D&C because your uterus has been injured and the healing process makes it sticky, at least this is the theory, and therefore you may have a higher chance of implantation, but not from a straightforward miscarriage. In fact, arguably, you might be worse. This way?
Yeah.
Okay.
You slid a little bit.
I slid.
Yeah. Okay. What if you struggle with vaginal progesterone? Would the oil be good enough?
No, but why are you struggling? I mean, there's like 4 different kinds, so you should be able to find one that works for you. You got endometrium, which we call vaginal fizz pop. You got crinone, which turns into lovely little crinone tumors eventually. You got prometrium, which spooges out of you, and you've got the custom compounded kind, which is kind of the same. It just kind of dissolves and oozes out. None of them are pleasant, but they all work well, and you should be able to find one that fits you. So the biology behind this is as such. When you release progesterone, it has a paracrine and an autocrine or endocrine effect. So what that means is some of it is local because it's coming from your ovary and it's going right to the uterus. For that level of interaction, you probably need it very close to the uterus, which is the vaginal. But some of it is getting into your bloodstream, and we don't even know all of the impact there, but whatever it's doing is being done through your bloodstream. So for that, you need the progesterone in oil. So do I know that for a fact? Yeah, because there's a new study coming out saying it's better when you have both of them.
I have a huge question for you.
Huge.
Huge.
I'm up for huge.
It's even got a
Drum
link.
roll.
It's even got a link.
It's got a link. All right, go for it.
Thank you so much for this forum. Love the evidence-based discussion.
Okay.
Question.
Yeah.
Does your clinic use the in vitro maturation of non-dominant small follicles in natural cycle IVF or modified natural cycle mild IVF? If so, do you only use it in specific cases?
Yeah.
This question is arising from the 2016 paper Infertility and Sterility non-dominant small follicles are a promising source of mature
Yeah.
oocytes and modify natural cycle in
Yeah.
vitro fertilization and embryo transfer.
So, listen, IVM is nowhere near the success of what you get from a normal IVF cycle. People have been playing with this for years. It was a big thing before we had GnRH agonist triggers to avoid OHSS. Now that we have GnRH agonist triggers, virtually nobody is using IVM anymore because we avoid the OHSS in the PCO patients. For the patients that have some eggs that are smaller and some eggs that are mature, you should not be trying IVM. You should be doing duostim. So go and do the retrieval for those larger follicles. Wait 5 days, at least that's what the study we followed did, and then start your shots again. And those smaller follicles will grow, and you get a second cohort that doesn't need IVM. IVM will never match the same results as conventional IVF. It just won't. So promising source is promising source. It doesn't mean it's going to work. It means, hey, this has a source of eggs, but why would we do that when you can just stimulate them to turn them into normal eggs again? And it's going to give you a much better result. In fact, interestingly, most of the studies that look at what's, we call it duostim because that was the name that was given to it, but it's called a luteal phase stimulation. So most of the studies that look at that actually support the concept that the second batch of eggs are even better than the first. Whereas with IVM, you're never going to get the same quality as you will with the normal IVF cycles. So don't try IVM. In my opinion, it's a total waste of time. We only do it if we get patients where we are expecting their follicles to be mature. They were 18, 20 millimeters, whatever. You thought they were going to be mature and you get none that are mature. Well, then I'm forced to do a maturation process and we're prepared for it, but you're also expecting lower outcomes with that.
Is it safe? Oh, there's a lot of vaccine and breastfeeding questions.
Yeah, vaccine and breastfeeding. Let me answer all the people that are waiting for vaccine and breastfeeding. It's 100% safe. There is no negative impact for your baby whatsoever. It is biologically not possible to harm your baby if you get vaccinated and it gets through in your breast milk, unless your baby expresses coronavirus spike protein in its body, which is impossible. So yeah, that would make you the source of coronavirus for some weird reason. So unless you are the source of global pandemic, I don't think you need to worry about it, guys.
Can one tube pick up eggs on both sides if left
Yes.
with one fallopian tube? I'm 38 with PCOS and adenomyosis.
Yeah, we think it can. So we're not sure, but we do believe so because there are patients that have conceived with only one tube when they ovulated from the other side.
You spoke about using both vaginal and PIO. What if you struggle with the vaginal suppository due to severe irritation? Would PIO on it be reasonable?
So like I said, there's 4 different kinds, so find one that you are comfortable with because there are multiple different types of progesterone and you shouldn't be severely irritated from all of them. If you are severely irritated, you probably need an evaluation of your vagina because it shouldn't be irritating to you. And if you're getting irritated, that's causing inflammation, which is hella bad for the embryo. So don't let yourself get irritated for sure.
Can I do IUI with one tube?
Yes, as long as you're ovulating regularly, or we can make you ovulate one tube, you can do IUI.
What is the best follicle size to trigger with low AMH over the age of 40?
So for IUI, they say that the best follicle size is around 20, but there are some people that believe that when your age is involved in there, you should trigger a little earlier. So I'd probably agree, and I'd say maybe more like a 18. But generally we aim for a 20 with IUI for most of our patients.
I had a retrieval and failed fresh transfer. My cycle started after stopping PIO. Now my next cycle is delayed. Cycle day 24, no sign of LH surge. Would you recommend Provera or waiting it out?
Oh, that won't make a difference. You can do whatever you want. You can take Provera and go ahead, or you can wait it out. That's up to you. Whatever's going to frustrate you less is what you should do. And get a preg test first before you do anything.
Why don't you charge for Neupogen, but other places do?
we don't charge for a lot of stuff other places do. So I am deeply and profoundly religious, as is my good friend Tarek here. So I believe my job is to help people. It's not about making more money. So we do our best with what we can to help people every way that we can. I really definitely need to go to sleep at night knowing that I did my best to help people. Not that I made more money, because God's been very good to me and my family, and I am doing this to help you, not to gouge you. So if we can avoid charging people and we have to take a little bit of a hit, you know what? My spending some money to help people is what God gave me this job for. It's not so that I can drive more expensive cars or have, more toys. It's so that I can help people. So that's why we don't gouge you. If we don't have to charge, we don't. If I have to take a bit of a hit and it's manageable for the corporation, then we do. So we try that often with as many circumstances as we can. And I'm really proud of everyone that works here, because everybody here goes out of their way to help our patients. And we love everybody for that. So that's who we want to be, and that's what I want to represent.
If you have only a few follicles, what do you recommend? Keep at day 3 or push to day 5?
That's the eternal question. So it depends in my mind, and we'll end with this one because we're going to go on forever. Otherwise, it's 9:12. Okay, so here's my theory on this. If you only have a couple of follicles for whatever reason, you're young and you have diminished ovarian reserve, or you're older and you have diminished ovarian reserve, it doesn't really matter. The decision on whether to transfer day 3 or day 5 should come from 2 really important things. Number 1, how many eggs did you actually produce? Because if you produced enough that your estrogen and progesterone went up, you have to transfer day 5 and they should be frozen, or you should transfer day 5 and they should be frozen. But if you only make like 1 or 2, the question is, should you do a day 3 transfer or a day 5 transfer? So here's my theory on that. If it didn't work, either way, day 3 or day 5, and you are going to move to doing donor eggs immediately, then my response would be do a day 3. Because no matter how good our lab is, and I'm very proud to say that our lab director, Dr. Fariba Khosravi, has put together a phenomenal lab here. No matter how good the lab is, it's not going to be as good as your body is for raising an embryo. We just can't match everything that the human body does. It's impossible. So it's literally the ultimate supercomputer. So we can't get to that level, okay? So putting it in on day 3 makes a lot of sense to me. But remember, that's, hey, if we fail, I'm going straight into a donor egg cycle. Because if it doesn't work, you're not hedging, you're not wondering what happened, you're not going to decide, hey, I want to try again. You're just moving forwards, and moving forwards would be donor egg. If you wouldn't go to donor egg, then you really need to know why it didn't work. So then I would say you need PGT testing so that you know you're putting in a genetically normal embryo. Why? Because if you produce 2 or 3 embryos and none of them are genetically normal, you really have to question whether or not it makes sense to do another cycle. And it may sway you towards, hey, how many more of these are we going to do versus should we move on to donor egg? So if you're sure you're going to just try once and then go to donor egg, it's really not necessary to pop them in on day 3. But if you're unsure of what the next step is going to be, you need to do PGT testing of those embryos so that you know you're producing some that are normal, and that way you have more information to help you with the next decision, which is, oh God, it didn't work. What do we do now? And you need to know, I produced 4 embryos, all of them were abnormal. Well, the likelihood's pretty high you're going to get the same thing the next time. Are you willing to take that risk, or do you want to proceed with donor? And at least it gives you the information you need to make an educated and informed decision. And nobody should be making decisions about any part of this unless you're educated and informed. So I'm going to leave you with that. Have a great night, guys. Thank you for watching. Thank you for all the love. I will get Tarek his Ember mug right now. And I hope you guys have a great evening. We will see you again on Fertility Factor Fiction next week. What do you want to do, the human growth hormone or the Neupogen?
Neupogen.
You want to do Neupogen?
I like the name.
You like the name? You know what? I think I'm gonna break with Tarek for once. I'm gonna do human growth hormone next week, and the week after we'll do Neupogen. Have a great night, guys, and stay safe. And please, I beg you, go get vaccinated. Go get vaccinated. Go get vaccinated. Go get vaccinated. Take care.